Y empezamos con el episodio número 31 de Sin Pelos en el Cactus. Y el día de hoy tenemos un invitado especial que es el doctor David Unwin. Así que prepárense, pónganse truchas, que lo que van a aprender y cómo se van a motivar los va a llevar a sanar y dejar potencialmente algunos de sus medicamentos. Empezamos.
And today I have an amazing guest, Dr. David Unwin. And for me, his trajectory has been inspiring because I was telling David right now that he is one of the few physicians that I can truly say that he is savoring, he's enjoying, he's just a bomb full of happiness when it comes to healing patients. And we're going to get into this because it's about lifestyle, it's about habits. And I would actually say that it's probably easier. Doesn't mean that it doesn't take effort, but it's easier to heal people than maybe we've made to believe or we've thought from what our education in medical school and things are. So I'll start with that. But David, true pleasure in having you here. And let's go ahead. Let's get started. So I think we can get started with what you were saying is that you just told me, Christian, it's like I was also like other doctors with a burnout and with just feeling that we're just prescribing things and we're not truly making a difference in our patients' health. What happened? How did that happen? How did you start changing or looking for something different? Because you told me you were on the brink of retirement.
That's true. I think all of us, Christian, we start off in medicine as young people hoping to make a difference. That's why we chose medicine. It wasn't to become rich, it was to make a difference. And I discovered when I was 55 years old, if I was to be honest, I hadn't really made the difference I'd hoped. And I was disappointed with myself. And my experience was that it felt like I was prescribing one drug and then another and then another. And it kind of made me sad. At the same time, I saw something like an 8-fold increase in the number of people with diabetes type 2 in the population I cared for. So when I started as a young man, that was 1986. And at that point, in the practice of 9,000 patients, we only had 57 with type 2 diabetes. We've now got 600. So you see, in the same practice, we've had an epidemic of type 2 diabetes. And go back to 2012, when everything changes, this epidemic was really making me depressed. And like so many doctors, I thought I was failing to make a difference and I should retire and play golf or garden or something like that. Two women is what happened to me, Christian. Two very important women. The first one was an angry woman, and she came to see me in 2012. And the point was, I knew from her computer record that she wasn't taking her drugs for type 2 diabetes. And so I'd written to her with the idea that I would tell her off for not taking her medication. But in actual fact, she came to tell me off. And this was because she had cut sugar and starchy carbs from her diet. Her blood sugar was completely normal, and she didn't need the diabetes drugs. She lost a lot of weight, and she said to me, "You've been giving me those drugs for 10 years now. You never once mentioned that starchy carbs like bread and rice are sugar. Never once. That medication gave me diarrhea, only I was too embarrassed to tell you about this. Now I've given up sugar and starchy carbs, my blood sugar's normal, and I don't need your drugs." And what really frightened me, she said, "Dr. Unwin, I wonder whether you're medically qualified. So I was scared, and you don't like complaints, but the point was, Christian, she was telling the truth. I had never, ever mentioned that bread, potato, and rice all turn into sugar. And I had medicated her without considering there was an alternative. And her anger was quite justified, and clearly I did have something to learn. But what surprised me when I investigated, well, where had she learned to do this? There were 40,000 other people all on the low-carb diet like her, and they were being ridiculed by their doctors. And that made me so sad. Yeah. This was in 2012. And I began to think anew about the increase in type 2 diabetes that I had seen, because if it was rare before, it could be rare again. So all these drugs, what if they're not necessary, as this lady had shown? And then we come to the second woman. So that's the first lady who showed me it was possible, and I should think about the physiology of type 2 diabetes. I should think about why people are unwell instead of just medicating. And the second woman, of course, was my wife, Jen. She's a consultant psychologist whose life's work is in hope in chronic disease and the difference that hope makes. And she's also a formidable woman. And she asked me one day, I was telling her I was thinking about retiring, and she said, well, before you retire, why don't you try and make a difference? Why don't we do something together? And Christian, this was my answer. I said, I'd like to do something for people with type 2 diabetes, but we're not paid specifically to do that. And this is the punchline. She said, David, how many cars do we own? And also, we've got 2 homes. I thought I'd married a doctor. Wow. Along the lines of, you should be ashamed. And I think, many of us, Christian, are trapped by money, the idea that we have to be paid for things. And since that time, I've done my questions about doing things in medicine are, is it fun? Is it effective? And where is it leading? And is it linked to the true causes of illness? And since I've had this new way of thinking about medicine, while forgetting whether I'm paid or not, I've been paid 100 times over because I'm so much more effective. And I see in every single clinic I do, I see people whose type 2 diabetes is put into drug-free remission in every single clinic. So Monday this week, I saw another one, and that's the 143rd patient now. So that the lady who told me off was the first patient because I'd never seen it before then. And now I've seen it 143 times. So I'm very, very grateful to those two women.
That story is just, it gives me, it's goosebumps, it's a beautiful story that you're mentioning there. And it shows you the importance of your partner, your wife, your soulmate, and how she actually helped you pursue something that you practically had given up on. And she made you believe in something. And I think by looking at your smile, by looking at just you radiate happiness, and that is something that I tell people. I've been through everything here. I'm interventional cardiology, but you start looking into things I've never looked into before. I live in the most obesity in the United States. It's been 7th year in a row now. One of the things that I always see is brain, psychology, emotion, depression, anxiety, which is worse than ever. And I do not believe that people have the tools to actually deal with their psychological issues. And most of the time, they're getting what we were doing previously for diabetes. They're just getting meds. Here's your Zoloft, here's your Sertraline. but they're not targeting their issue here, which brings me to the next point. The point of physician burnout. I've made an observation in my weeks, and not only by what I felt before, but it's like I came to a conclusion that most people live in a 48-hour window gap of happiness, and the rest are miserable, meaning everybody's dreading that Sunday afternoon, and then it's Monday. Nobody wants Monday. Tuesday, they're like, shit. Wednesday is like, well, I'm halfway through. Thursday is like, one more day and it's Friday. And then Friday comes and it's Friday afternoon, they're off work. And basically what counts is Friday afternoon. Then you've got Saturday. Some people get drunk and they're hangover. And then they wake up on Sunday afternoon. But by Sunday afternoon, they're already pissing off because Monday already comes. So it's that perspective that, I think a lot of physicians, me personally, even by doing procedures, interventional cardiology, it was like, I got into medicine because I did not want a routine. I didn't want to follow a part. And it turned out, and when you're only prescribing and medications, which I need to very clear, it's not that I'm against medications. Medications are wonderful when they're used properly. Intermittent fasting is wonderful when you are using it properly. So this for me is extremely important, because I believe that if you're happy with what you're doing, it's easier to help the patient and show empathy and sympathy. And that is another observation, that I do not judge the patient.
Yeah, I've got a point to make on that, Christian. I realize now that part of my problem was the habit of seeing patients as a problem. And again, it was my wife who said, instead of framing them as a problem, why don't you reframe it as an interesting puzzle? An interesting puzzle that you and the patient together, collaboratively, are going to try and solve. So that for me, instead of seeing a list of people who are going to suck me dry and exhaust me, I see potential. I'm intrigued. I'm curious about people. And that's helped immensely. And many of our colleagues, it makes me so sad when they see somebody who's reversed their diabetes and they don't even ask how. They're not even curious when you see this miracle and they don't ask how. Those people, those clinicians have lost hope, and they're not curious. And so for me, the habit of reframing problems as puzzles has been very, very helpful.
You said that, for example, patients being judged by their physician, and I still see that, we see that a lot in social media with our colleagues, and it appears to be a nutrition war sometimes. It's like the left and the right, the good side, the Force, and the Jedis and whatever, and the dark side. For me, it's like whatever works for the patient is best, but I'm already biased, because I'm going to tell you why I'm biased. Personally, I do not believe that there is a better diet. That's my belief. It's not that I'm saying, because a lot of people are going to get pissed maybe. I do not believe that there's a better diet than a low-carb diet in order to fix the metabolic syndrome. And I say that now from experience, not only from literature. I say it from experience because I can tell you 90 or 95% of my patients have that here. It's the most obese eat in the United States. You see it left and right. You see kids and you can even smell it, Why do you think that there is such a controversy to a certain point in which, I've even seen people attacking you and you're like an angel. You're like the most peaceful man on earth. And then it's like, you probably just ignore it. But it pisses me off when they're attacking you. I'm like, why? Don't you see the results? So why do you think that is?
Christian, I am also troubled by this, because here we are, you and me, I've got great results. I'm not using drugs. And the world's a slightly better place because my patients have better health. And yet, oddly, very oddly, I am attacked and have been since 2012. So I'm endlessly worried by this. And what is going on? It's so odd. There are different factors, I think. One of the factors is it's interesting how quickly a situation is normalized. So when I went to medical school, which was in the end of the 1970s, we were taught about carbohydrate counting to help people with diabetes. And the idea that carbohydrates put up blood sugar and that a high blood sugar was not great was absolutely what we were taught. And yet, how interesting, as there have been arguably improvements in pharmacology, we now have the paradigm where most younger doctors are thinking about drugs more than they are thinking about lifestyle. And I think another thing is doctors, we flatter ourselves that we're scientists, people who think things through. But I don't think we are. I think many doctors are memorizing protocols and so on, and we're no longer thinking about the true causes of illness. We instead are defaulting to what tests shall we do and what medication would be the most effective. Now, like you, of course, I do use medication in every clinic that I do, but my practice uses the least amount of drugs for diabetes of all the practices in a 50-mile radius. So we save, let me think, I suppose dollars would be the thing for you, wouldn't it? So we save about $70,000 or $80,000 per year on the drugs for diabetes alone in my practice because we're using lifestyle. And then one final point. I think it's very hard to admit we were wrong. It's quite hard. It wasn't nice to be told that I was wrong. And I think many people, their first response is to be defensive and say, I'm not wrong. And I wonder whether the more senior you are, the more difficult it is to admit you were wrong. So I see this as something, it's a grassroots revolution. And it started with the people like that lady. And then fairly successfully, it's percolated into primary care because we have such exposure to patients like that. And I feel that it is the academics and the professors who are the final and last people to admit that we could perhaps do things better. And yet, a look around the world, there isn't every country I travel to, the pandemic of metabolic ill health is plain to see. Just go into any supermarket in any country and look at what people are buying, and look at look how big their belly is. So those are some of my thoughts. I think you've probably got some others.
No, it's very interesting, and I think that aspect of being wrong, I mean, I think with my ADD, I've been wrong since I was a kid, so I got used to being told that I was wrong. So, yeah. And I was always questioning things. I mean, in my brain, there's, for example, multiple choice questions for me are a freaking torture. I mean, because, I'm always thinking, but what if, which actually is what led me to figure out in 2017, what if what I'm doing for me is not working because I'm gaining weight? This crap is just not working. You're freaking cereal piece of crap at night. Eat less, do more. That was not working for me. I remember being an interventional cardiology fellow, busting my chops, working, and I felt miserable, So it's all about the questioning, but there's an observation here which goes with your thought. In medicine, when you're a student, or at least from my experience, or you're a fellow, or you're in your PGY, whatever. Depends on, of course, your teacher or your mentor or your professor. But when you question stuff and you're in your early stages you're like, what on earth do you know? It's like shut the hell up. And sometimes, at least in the Mexican or in my training, it was like you could even gain like a punish on-call day or something like that, you know.
Yeah.
And in my cardiology training, my chairman was a freaking dumbass, Japanese, obtuse as can be, which I can say that now because I have no repercussions to saying the truth. Nobody liked the guy, but if you question what he was saying, it doesn't matter if you're faculty or if you're a student, you were gonna get it. People were scared of that, and I think in medicine that basically halts questioning. It halts. Good.
That's a very interesting observation, Christian. That happened in my training. It was almost like military training, where we were trained to obey in what was a hierarchical situation. So the consultants were not to be questioned. Nobody was to be questioned. And that's what's in science, what you have, of course. Science is full of interesting questions. Science advances by disproving things. So you have a hypothesis, and then you've got to try and disprove it. That's science. What I experienced, and you, was that if I dared to question anything, then you regretted it. Yeah. You really regretted it because the system was there that we would obey and question nothing.
100%. And I think by questioning, that is what actually has led, at least to me, to what might be a certain extent of the happiness that you're experiencing. I do believe that by going away from the traditional thought and questioning what's going on here. I mean, when I got to McAllen, I was seeing people in their 30s telling me, I came from California having chest pain. I'm like, come on, you're 30, man. And nothing, you don't have anything. Do a stress test. Like, well, that's weird. Then I take them to a cath lab and like, holy crap balls. I mean, you actually have a significant lesion that we need to intervene upon. And I started joking. It takes effort screwing up your coronaries by the age of 30s. Of course, you can have other issues. You have genetic factors. But when you start seeing what they're eating, but they are not eating nutritious food. And we are plagued with crap food all around. And then you start seeing news, for example, the USDA recently, and they come up with this statement saying that there's not enough information or data suggesting that ultra-processed food is bad for you, and that comes from 10 RDs. I mean, for the love of God. We were talking about the addiction, which is also a controversial subject about food addiction. It's like, call it whatever the hell you want. If you don't want to use the word addiction, call it problematic. But there's certain food. You go ahead.
Yes, I just to interrupt there. So for me, when you see intelligent people doing stupid stuff that impacts on their health, you have to ask why. So who smokes cigarettes and has no idea that cigarettes cause cancer? And they're not stupid people. They know, but they're addicted. Alcoholics don't need telling that alcohol is their problem. And for me, that was another thing that until 2012, I never saw somebody I regarded as a food addict. But if you actually ask people, is it possible? I see that, you're eating the very food that makes your diabetes worse. I wonder if you could be addicted to that food. When you ask that question, again, I'm finding food addicts, people addicted to ultra-processed food in every clinic I do. And some of them are very young. Some of them are in their teens and they can't give up energy drinks or breakfast cereals or whatever. And this is a contributing factor to sell more junk food, of course. How wonderful. They've got a product that's addictive, in my opinion. But it's a contributing factor to this pandemic of metabolic ill health. And people are eating things they know may not be good for them, and they struggle to stop.
One of the things that I tell patients is that they need to learn to distinguish between craving and hunger.
Yes.
And so that statement of everything with moderation, I tell the patients that it's the biggest lie that they've ever heard. And when I see, and I don't care, because I mean, this is going to different platforms, including X, but I don't care if an RD or an nutritionist gets pissed off. But I don't give a crap. That just tells you that you are not dealing with my population. And my population, once again, the most obesity in the United States, what do I see? I see the worst of the Mexican food, because it's a border city, with the worst of the junk food from United States, and they've merged it, and they've done some horrible crap that basically gives them a huge dopamine surge, and it makes them feel well, and then they're hungry. Well, they're not hungry, they're craving. So that's why I ask them. It's like this with moderation. Let's change the subject. Let's do this. Before you say everything with moderation, let's do a scale from 1 to 10. And tell me how difficult it's going to be for you to stop eating whatever it is that you're going to be putting in your mouth. So if it's a tamal, if it's a taco al pastor with this wonderful creams and everything, if you already know that you can eat that when you're not hungry, and after you eat it, you're going to want another one, then you probably should not eat it. Because I do not know anybody that struggles stopping eating broccoli with salmon.
Absolutely. I agree. And the whole idea of moderation, what does it even mean? You know, is moderation so many grams? What is it even? It's a useless moderation. We all have a different view of what moderation is. And it causes endless confusion. It's so unhelpful, so unhelpful. So I so agree with you. Please let's stop using the word moderation, because it doesn't help in clinic. It doesn't actually help me save lives talking about moderation. And another thing I would say, if you have type 2 diabetes, to you, sugar is a type of poison because you can't metabolize it and it will damage your arteries. So the question then is, how poisoned do you want to be? Do you want to be very poisoned, or maybe moderately poisoned? I would rather be not poisoned at all. And so I have type 2 diabetes, and I do not eat starchy carbohydrates. I haven't had bread for 12 years because I choose to not be poisoned, not moderately poisoned. And that's my way of chatting on about moderation.
Yeah, and then comes the people saying, do not be demonizing food and blah, blah, blah. It's like, it's not demonizing. I mean, if I tell patients, if you have the guts of eating half a loaf of bread and you're going to be fine, that's going to make you happy, and it's not going to trigger you eating more, then fine, let's explore it. I'm not blinded to that option. The chances are you're not going to be able to, just being realistic here. It's knowing the patient. So that's the key. When somebody gets pissed when we are saying this, that's fine. Do you truly know your patient? Because I know mine. And I know my patient. Go ahead.
Well, I do, because I've looked after them since 1986. So if you look after the same bunch of patients for that many years, I really know them. Again, the model I prefer is supplying relevant information. So, of course, the action depends upon the patient, but I'm supplying relevant information for their condition. So it's not about bullying people. The other thing is, what are their health goals? So I try and start with hope before I start giving information or giving advice. And I find that particularly when people are newly diagnosed with type 2 diabetes, they're really interested in drug-free remission. They're really interested in having better health. People are not foolish. They'd rather be healthy. They really would. And I think it's our job as doctors to give them hope and help them move towards the light. A thing I didn't do for so many years, I just medicated them. One other thing I would like to say that makes me laugh now. So why didn't I see a single case of drug-free remission between 1986 and 2012? And also, how about the people? I didn't see people losing weight or improving health. And what's so amusing is I blamed the patients for not taking my advice. But, Christian, what was the common denominator? It was me. It was me, because my advice was rubbish. Yeah. And that's why if you give poor advice, then the results will be poor. And since I've given advice, more useful advice, that's why the clinics have improved for me, but also the other doctors we have 9 doctors in our practice and 3 nurses. So my work's been translated now, I think, into 35 languages all around the world. So we're doing something right.
Yeah, and I mean, what I want, other people to listen here is like, we're not saying that this is the only option. I mean, I will acknowledge that there's great doctors that they're doing a vegan, a vegetarian diet, and whatever they want, and they're helping patients, and I'm happy for you. But I can tell you one thing, for example, if you know my population, you will not have a Mexican or a Hispanic one here from McAllen going vegan. That's not going to happen. I mean, I can tell you, you can chug all the tofu you want, but my patients, they will smirk, they will laugh at you, they will tell you to go to hell. I'm not kidding, and I will not do it either. So I respect other ways of eating, but I'm realistic on the expectations and how I'm going to be able to implement it to my patients. So that is very important in knowing your set, and it doesn't mean that this works for everybody, but I can tell you it works for most people here. And it's the concept. Another a big issue that you might have encountered is that I see people using the terms loosely between keto and low carb. And that is a big problem, because most people will come to their physician and they'll let them know, I'm doing keto. No. You're not doing keto. I mean, you might be doing a modified keto, but you're not sticking 70 or 80% of saturated fat in your mouth. What you're doing is a modified Mediterranean diet.
Yeah. What I've started, in order to understand my patients better, I asked them, would you please photograph with your phone everything you eat for the 3 days before you come and see me? And those photographs are so very enlightening. So you will see keto people who are eating breakfast cereals and potatoes. And but what that does is it helps me understand where they are and the extra information they need. So I find photos, a photo diary, very, very illuminating and so interesting. Equally though, I see some amazing tasty meals that I'd eat myself, and then they're very pleased because, of course, I'm full of praise.
Yeah, I agree with you, and that's. I mean, I haven't thought about it, but it can help us with our patients. And what I tell people is, you know what? What I try to do is I get the best from the carnivore world, I get the best from the vegan world, and I find them in between. That's it. I mean, there's just so much fighting with this stuff that well, where's your randomized control trial? Jesus. I mean, it's like, do I really need that randomized control trial to already do what I'm doing and helping the patients? I mean, for me, everything started in 2017, and I'll tell you a little bit of the story if you allow me. But for me, when I was able to help a patient lose 2 or 3 pounds, I was like, wow, that was good. That was amazing. But I've helped people lose 100 pounds in a year. That's before Ozempic, Wegovy, because for me, it was so intriguing that I also became certified by the American Board of Obesity Medicine. Interventional cardiology. I'm truly focusing on prevention, and I consider myself now a functional cardiologist, because what I realized, if you come to my cath lab and I am not able to change your habits, you'll be back in a year and I'll be stenting that thing again, and that is just a vicious cycle. So that is extremely important. And I think in my case, for you, it started with 2 women that made you change and made you question what you were doing. For me, I would say it was probably vanity, because I got here, it's 2017, I'm doing everything right, I'm eating less, I'm moving more, and I'm gaining weight. I'm like, what the hell's going on here? I'm chugging my cereal, my Cheerios, good for the heart, and cholesterol, bullshit. And I started doing this low-carbish thing, and I lost about 25 pounds in 3 months. My labs look fantastic. All of my metabolic factors, variables, triglycerides went down to 70, LDL was 70, HDL was 70, like it's 70. It was, what's going on here? I mean, I thought that if I was doing this, I would be harming myself.
And, well, I had a very similar experience. So in the beginning, I was criticized for what I did and received hate mail and all sorts of things. But actually, those people did me a great favor because I started keeping really careful records. And when you do that, you start seeing the most amazing trends. So the first thing that was improving was liver function, really significant improvements in liver function. And then I'm so happy to hear you mention triglyceride, because previously I didn't really know what to do about a high triglyceride. And you just vaguely thought, well, eat a bit less and maybe exercise and we'll do it again in a year. But you see, really big drops in triglyceride and fast too, and the HDL. So I began to look forward to the lab work coming in. It was like the treat at the end of the day, because on the low carb group, the results were astonishing. I had never, in fact, I thought I was a fraud. I was worried about telling the world because I thought, compared to, say, a drug intervention where you're seeing 5 to 10% improvement, I was seeing improvements of maybe 30% to 50%. And I was worried because I thought, well, this looks ridiculous. But I saw it in patient after patient after patient. And that's now the basis for so I think the practice, we've published about 20 peer-reviewed papers now, just based on the audit that's going on in our clinic.
For me, it was funny because I remember getting into cardiology because I'm like, I do not want to deal with your triglyceride. Well, I mean, with your diabetes, with your glycosylated hemoglobin, with your insulin, I just don't want to. I saw myself as I wanted to treat the complication, and it's like a video game. But time happened, and then I was seeing that I had to get into this because, it's been like exciting. It's like it's a puzzle, as you said. I'm going to tell you, salt has been something extremely interesting for me. But I started removing medications. Like your interventional cardiologist did. What the? So yeah, 25%. I remember contacting Jason Fung, which he also gets shitloads of hate because I was experiencing this back then, and I was able to decrease the dosage and even stop insulin and stop medications so you can give me all the hate that you want. But I was achieving that. And
I know I used to think, what do you want me to do? Put them all back on drugs. These are individuals that we're talking about, individuals coming off insulin. Many of them come off their antihypertensive medication. Many of them are off diabetes. And for those individuals, they're so proud and their lives are changed, and yet you're criticized. And I just thought, well, it's so ridiculous because as a clinician, I'm not going to go, hey, start eating bread and let's restart the insulin. It's just so ridiculous, so ridiculous. And please mention salt because I love to discuss salt because, of course, we're blaming the wrong white crystal, aren't we? We're blaming the wrong white crystal. So you tell the viewers that's about.
Definitely. And one of the, it's the salt, and I had another point that I wanted to make with this. So for me, one of the turning points in this was my own colleagues telling me, you're going to kill people. I'm like, how the hell am I going to be doing that when I'm fixing absolutely every single variable in the metabolic syndrome? It just doesn't make sense.
Yeah. I used to think the same. I used to think, well, what are they going to die of? Because I've been measuring every single cardiovascular risk factor and they all improve. So if death is coming, I wonder how. And certainly it hasn't happened yet. So yes, I'd had exactly the same experience.
For me, it was funny because you see everything. You see triglycerides go down, you see HDL go up, you see LDL and it becomes large particles, you see inflammation going down, protein, C-reactive protein goes down, they start losing weight, you start removing blood pressure medications, they're more active, they're more energetic, so, I mean, their glucose is fabulous. So, sometimes people argue, well, your LDL, and they give you shit because of the LDL. So I remember making a post very clearly on DAPA heart failure in the European Society of Cardiology meeting in 2019. I think that the organizer even blocked me because I made a post there. And I told them, all you guys are applauding your dapagliflozin and your SGLT. And I showed them mechanistically how the results of that was very similar to the low carb, including the elevation of the LDL. But everybody was standing ovation. So to me, it's frustrating when you talk about prevention, but for your prevention is your medication. Because I do not see a meeting in which you have a true session about adequate, important, and successful lifestyle intervention. I'm not saying that doesn't exist. I'm just saying that you don't see it often, at least in a cardiology meeting. I know that there's cardiologists who are doing this and doing amazing work. Why on earth don't we have a keynote speaker talking about this? I have no idea. So, going for salt. This is beautiful. So one of the things that I've been getting into a lot is electrolyte deficiencies and this more of, learning that magnesium deficiency is something common and you can have normal magnesium levels in your blood. That doesn't mean that you're not deficient. Well,
hey, let me talk. We'll do a deal. You can talk about sodium and I'd like to talk about magnesium.
Perfect.
You go.
So one of the things that started happening when I started implementing the low carb lifestyle and fasting was that people started losing a lot of water. When you lose water, you lose sodium. And when you lose when you have this the sodium changes, then people start getting the keto flu and all that stuff. And the amount of sodium that a low carber or a person doing fasting and is going through a ketogenic process and is using the glycolysis and you're depleting your glycogen, which is adhered to 3 times its weight in water. You're throwing water, you're throwing electrolytes. So if you are not supplementing with sodium, you feel like crap.
Yes.
One of the misconceptions with salt is that salt is actually sodium chloride. So when they tell you you should not eat more than 3.5, 2.8 grams of salt, that's you're actually referring to sodium. If you actually have 6 grams of salt, that's actually 2.4 grams of sodium. So if you're not eating processed food, you're not going to get much salt from your chicken breast with your broccoli or your meat. So you actually need to give salt. So we start getting into a process here that you need to be telling patients, including even those with heart failure, that they need to start taking more salt. So, but be mindful because my cardiologists are going to have a heart attack. First of all, salt, sodium chloride. Now understand the next concept. You need salt, you need sodium for the diuretics to work. But you've got these guys chugging down 2 grams of sodium or less. And then you blame them because they feel shitty and they feel miserable. If you've done low carb, if you've done keto in the past and you did not supplement with sodium, you know you're going to feel like crap. And then you see it. Go ahead.
No, I had exactly the same experience where particularly as I'm a runner and I discovered my blood pressure improved, I had a marked diuresis, but I started getting muscle cramps. And I discovered that I needed a lot more salt, and so did my patients. But despite all of the extra salt I had, my blood pressure and the blood pressure of my patients improved significantly. So the average person gets an improvement in systolic of 14 millimeters of mercury and diastolic about 8 or 9. And even though they're having more salt, and it took me 2 to 3 years to discover what was going on. And we have known since 1933 that insulin causes renal sodium retention. So a high carb diet is a high insulin diet, and your kidneys on that high insulin diet will retain salt. You are hoarding salt. Then when you go low carb, you wee it out. And some patients lose an astonishing amount of fluid. I've treated heart failure on 2 occasions, really severe heart failure with low carb, and the diuresis meant they could come off the water tablets. And it's interesting that I wrote a paper on this with a professor of cardiology, Professor Brady, where we looked at the improvements in blood pressure and the deprescribing. And he covered for me the physiology, the idea that insulin causes kidneys to hoard salt. And then you go low carb and you wee out that salt. And that's why you have to have more, because God didn't design you to die just because you live by the sea and ate salty fish. We had homeostasis. We've short-circuited that homeostasis because what wasn't foretold was the high carbohydrate environment that so we're not on a low carb diet, we're on a normal carb diet. Modern society has a high carb diet causing renal sodium retention, and is one of the main causes, in my opinion, of high blood pressure.
Yeah, definitely. And touching upon what you just mentioned, so we've seen those heart failure patients. There was which, by the way, I think, was that paper published, in the 2019, approximately 220? Because I remember speaking with you about it. I remember speaking with you about different mechanisms through Twitter.
We did. Yeah, we did.
So
it's been a very popular paper. Yeah.
And so around those moments, I remember having a heart failure patient that is like, he's just resistant to diuretics. Now, interestingly enough, there's a protocol in Europe in which they use hypertonic saline in patients with heart failure in order to promote diuresis on patients that are not responding to Bumex or furosemide or blah, blah, blah. Now, if you think about the mechanism which was proposed by the nephrologists that are actually using or doing this, they give, you need the sodium to pull the water. If there's no sodium, there's not going to be any water being pulled. So the interesting factor here was there was a paper in which it actually showed the patient with heart failure, and this was in JACC, that actually had higher mortality when they had very low levels of sodium ingestion. I think the paper was later retracted because of blah, 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 but that was actually tweeted back then by Eric Topol. I remember that paper very clearly. Now, that brought me to the concept, and I was looking into this, about using hypertonic saline in order, at the same time that they're using diuretics, in order to promote the diuresis in heart failure patient that have not been responding to it. So I had one patient that was discharged from the hospital, and he left on oxygen. He did not respond to diuretics, and he was miserable. I remember him in the clinic, and it's like, dude, I've got nothing else for you. And then I'm like, do you? Do you have something else? So I'm like, well, I have something else. You know what? Let's do a low-carb lifestyle. Let's do intermittent fasting. And I want you to eat more sodium. What the hell? I've got nothing. You want to try this? Yes. So I remember, he was on 80 milligrams of Lasix. He was on 2.5 milligrams of metolazone. He came back next week.
Yeah.
He had lost 22 pounds. 22 pounds. We were not able to do that in the hospital with IV diuretics. Now, I wasn't expecting 22 pounds of water. I remember tweeting it. You can find the tweet around there. It's 219, I think. And he came back. He was not using oxygen. He was walking. I'm like, what the earth is going on here? And that for me is it's exciting. But if you tell this to any other cardiologist, all you need to do is get your old train of thought and just think about the physiology. Does it make sense what I'm telling you? Can you have normal sodium because maybe those electrolytes are being pulled from your bones, just like magnesium and other things? If the patient is not getting sodium, how on earth is he going to use the sodium to remove the water? So I'm not saying that, hey, go full blown and eat all the sodium in the world that you want. But, I mean, that is a very important factor. And then there's another beautiful segment when you are doing low carb, and then you have hypertension, and then you have diastolic dysfunction and concentric hypertrophy, blah, blah, blah. And here it is, that insulin by itself has 4 different mechanisms in which increases blood pressure. So if you are in a craft 4 and you're always with a very high insulin, then you're going to be producing more endothelin-1, vasoconstrictor. You're going to be producing less nitric oxide, vasodilator. You're going to be promoting smooth muscle cell growth by the IGF, by the growth factors related to insulin. And then you've got insulin stimulating the kidney to absorb more sodium. 4 mechanisms in which hyperinsulinemia will lead to hypertension. And that explains why when you are doing this in a month, you are able to stop from 2 to 3 blood pressure medications, which I've done with my patients.
Yeah.
But it sounds like witchcraft and heresy, you know? So, yeah. I mean, and you're seeing it.
Just to add something into that I've been focusing on a little more, really because I've had a lot of contact with Ben Bickman. And you were talking there about hyperinsulinemia. And I think we often forget to explain to patients that what's going on is that your insulin isn't working as well, so you're insulin resistant. So the body's response to that, the only response to insulin resistance is to ramp up the production of insulin, and you become hyperinsulinemic as a reaction to insulin resistance. So you have actually 2 problems there, insulin resistance and hyperinsulinemia. And I think it's just an interesting thing to remember, because otherwise people don't understand why would you have more insulin. It's because it's not working as well.
And it goes, your ears, I see you quite choppy. Can you see me okay? I mean, your audio is fine, so that's okay. Okay.
Yeah. No, I can see it clearly.
Okay, very good. So there's this thing, you know, there's all this. Now there's studies out there, and that's I mean, there was a study back, I'm not sure if it was in the 1940s, in which they had a dog, you know, there was dogs. I don't know that they would allow this study anymore, but they had these dogs with one leg, which was getting constant infusion of insulin. The other leg was getting a normal saline. By the end of 8 weeks, the leg that was actually getting the insulin administration, the infusion, developed atherosclerosis, developed calcification, developed, thickened endothelium, while the other one didn't. I mean, you've got the data there. I'm not telling you, hey, this is the only way, but in our population, which keeps getting fatter and sicker, sometimes I feel like it's the fit guys that say that this is bullcrap. Well, it's bullcrap for you because you've got 20 pounds more of muscle than your regular Joe. So the way that your muscles are going to chuck down the glucose and improve that's very different. We cannot implement that same concept to the majority, in which I would say right now that the statistics would say that 8 out of 10, or at least 9 out of 10, are not metabolically healthy in the United States. So,
well, I think you just to look around, as I say, just look at the people. Go to a hotel anywhere in America, and I find it astonishing how the size of the breakfast, the size of the people, the size of the children, and I don't understand how there aren't placards in the streets. And I think it's because it's come about over the last 20 years that the danger is it's being normalized. That people just think children are fat. Well, they shouldn't be. They really shouldn't be. And one of the reason this is urgent is because when my generation has died out, nobody will remember that diabetes doesn't have to happen. So when I was little, I'd never heard of diabetes. I didn't know anybody with diabetes or asthma or depression. people just weren't ill very often. And now my clinics and yours are full of this. And I think there's a danger of normalizing so many chronic illnesses. And then we'll forget about prevention. And it's really important for young people that we don't forget about prevention.
I know that what I'm saying, because I'm transmitting this in X as well, and there's more colleagues, and I usually do my content in Spanish, but they're listening to me, and you might say, well, here, this guy is full of crap. Well, let me tell you something. As an interventional cardiologist, I get requests for me seeing pediatric patients, not for heart issues, but for help dealing them with their weight. That's to a point which I have achieved in my community. People want to see me for lifestyle prevention and implementation of this, because they know that what I'm telling them, it works, and they like my demeanor, how I communicate. I joke with patients. I'm not the kind of guy like stuck up. It's like it's a conversation. I think that's extremely important when we're trying to help the patient and motivate the patient. Which brings me to the next point. What makes you, well, do you have any tips on how you motivate patients to actually make the change?
Yes.
Okay.
I do. And a lot of this has come from my wife, Jen, who, as I say, is a consultant psychologist. And it's odd, really, in medicine, who are the experts in behavior change? Psychologists. And yet, we don't really think about psychology in medicine when what we're trying to do with most diseases of modern life is change behavior. So we really do need to think about psychology. And of course, there are different aspects of what my wife would teach. The first thing, I think, is the value of hope. So you've got two approaches. One is to try and frighten your patients. If you want, you feel like you'll die, but then you find they don't come back. And also, grown men don't like being told off. So I used to tell patients off, and then they wouldn't come again for 2 to 3 years, which I suppose used to suit me just fine, but I wasn't being effective. So rather than telling people off, I think introducing hope into consultations, because if that's all you do, it's really powerful because you've left them wanting more. If you don't introduce hope, they'll say, I couldn't possibly give up bread, or I couldn't possibly give up rice. So you failed in your motivation. My patients don't tell me I couldn't possibly live without bread, because they do care about their health. I'm talking about, are they interested in improving their health generally? So they could look better, have better skin. They don't need as much sleep. They're more energetic, as on top of blood pressure and all the other things. So motivating people is very important. Another really important thing is supplying relevant feedback. Feedback is how we know we're doing a good thing. So I'm really flexible when it comes to blood tests, or indeed using continuous glucose monitors. So I prescribe those against the guidelines, because I find the immediate feedback that my patients get, they just see so fast, like, what was that spike? Oh, it was breakfast cereals, so don't eat breakfast cereals. So the combination of hope, you could have better health, add to that feedback, so that they know when they're doing well. Because, of course, no two people have the same diet. My wife and I don't have the same diet. We individualize, each of us, it's like a lifelong experiment where you're trying different diets to see which suits you personally. And feedback is how you know to tweak it. And you may need a different diet at different stages of your life.
With this continuous glucose monitors, and I see a lot of people, coaches, and saying, it's normal for your glucose to spike. I'm like, okay, but they're missing the picture, because they're not looking further. When you see a glucose spike, okay, and let's say person 1 and person 4, they both achieved normal glycemia in an hour or in 2. Fantastic. It's a glucose spike. It's over. You see, it's done. No, it's not done, dumbass. Because if you're a craft 1, which have no insulin resistance, and you're a craft 4, which means that you have bad, severe insulin resistance, dancing tango with diabetes. Well, we're talking about different levels of insulin at a given point in time, but the guy in craft 4 already woke up with 50, let's put it, milliunits of insulin. And then when you ate, it goes to 100, and then you are basically practically all day long because you keep eating your snacks and bull crap. So you're always high. So glucose spikes is just the first piece of the equation. It's what that glucose spike is actually doing, because it's going to be different in the sport guy, fit guy, because then his insulin is back to normal, back in 90 minutes, but the other guy is high all the time. And we already know all of the things that hyperinsulinemia causes, you know?
I've got something to add to that. It's about the urgency of prevention early in the natural history of diabetes. So we've been auditing my work now at the practice since the very beginning. And I know that if you have pre-diabetes, I can get a normal blood sugar for you in 93% of cases. So I can reverse pre-diabetes in 93% of cases, and that's at 2.5 years afterwards. So really, we just about sort them all out, bar some of the carb addicts. However, if you wait, and you wait until I diagnose type 2 diabetes, it's going to go down to 73%. So people who are freshly diagnosed with type 2 diabetes, I can cure them in 73% of cases. So you've lost 20%. If you wait another 5 years and you've had diabetes for 5 years, I'm only going to get remission in 50% cases. So you see, I like it. The idea is one of metabolic aging. So it's much easier if you're going to intervene. The low-hanging fruit are at the early stages. It's so much easier to do. So much. I'm not saying you can't get. I've got people who've had diabetes for 20 years who achieve remission. But it's just, you stand a better chance earlier, and you shouldn't wait because your metabolism is losing elasticity by those continual spikes are probably aging you. Not are, definitely, but may well be aging you. And you'll end up with a harder situation to sort out in a few years' time.
One of the things that I've used over the years, and I found it a fantastic tool, is your tables. That comes from the Public Health Collaboration of United Kingdom.
The teaspoon of sugar equivalents.
I mean,
I hope you're going to share those with the...
I always share them, and I actually got into trouble one time.
Yeah.
Well, not in trouble, but it's like... So basically what I said is like, well, here you have a banana, and how a banana can stimulate your blood glucose, depending on the individual, like 6 teaspoons of sugar, let's put it. And then that gets mislabeled. It's like, well, what you're saying is that a banana is the same thing as 6 teaspoons of sugar. No. I'm not saying that it's the same thing. I'm saying that it's going to give you an equivalent in how it's going to raise your glucose. And if you have heard anything that I've said right now, it's not only about the spike of the glucose, but it's how your malfunctioning body is responding to that glucose spike depending on how badly you're resistant to insulin. Craft 1, Craft 4. So that is extremely important. In my population, I can tell you 70 or 80% of the people will have probably a Craft 4. I mean, they wake up with insulins of 120. Like, holy crap. So those tables that you've designed, you've met it because I think you also struggle, like many physicians, to like help people understand how that, and I think it's beautifully done.
Thank you, Christian. What I needed was a model to help my patients understand the consequences of dietary choices. And I was trying to find, I only have 10-minute appointments, so I work for the state. So you only have 10 minutes with each patient, so I have to be quick. And I have to find a quick way for you to understand how what you are eating may affect your blood sugar. And so the tables began with the glycemic load of particular portions of carbohydrate foods. And then what I found an expert on the glycemic load, Dr. Jeffrey Leibsey. And together we've actually done, there are 7 infographics. And the best example is boiled rice. So a small bowl of boiled rice, 150 grams, in terms of what it's going to do to your blood sugar, is approximately equal to 10 teaspoons of sugar, approximately. And it shows you that if you have type 2 diabetes, white rice is really a poor choice. And it helps patients understand really fast that actually, why don't you eat food that doesn't put your blood sugar up? There are loads of delicious foods. Really type 2 diabetes is as simple as why not eat nutrient-dense food that doesn't put your blood sugar up? Because on the whole, your steak and your broccoli and your salads and your omelets, these things are not going to put your blood sugar up very much. The infographics now are actually in, I think it's 35 languages, and they're not copyrighted, so please steal them. I don't make any money out of them. And if anybody wants the full 7 in whatever language you want, and I'm pretty sure it's in Spanish. In fact, I know it's in Spanish.
Yeah, it is.
All you do is Google Unwin, sugar, and PHC, and they're all there. Steal them, please. Thank you.
They're all there, and I think we need to put some tacos and tamales in the future, and I think that'd be interesting to see. But hey, we missed the magnesium thing. We focused on salt, and because there's a lot of controversy as well. I mean, once you start looking into this, you start seeing that there's a true deficiency, and there's like a pandemia of magnesium deficiency. But many doctors saying, this is bullshit. This is just you wanting to sell products. But I've been getting into the literature, and please tell us a little bit more about this.
Well, it's just a story, really, how I got into magnesium, and it begins with a cow. So I've told you already, I have a wonderful wife, and we do this thing every now and then, which is we buy each other a gift. And the idea is you have to try and think what the other person would really want. So you don't buy your wife a gift that you really want. You have to think, what would she like? And my wife had to think, what would I really like? And so one day she says, right, bring your boots and a coat. And she took me to a field and she said, you can buy any cow in this field. I have paid for it already. And we live on a farm, and I'd always wanted a cow. And so we bought a cow. But what's interesting and relates to magnesium is the farmer said, whatever you do, you must give the cow a magnesium supplement, because the grass now is magnesium deficient and the soil is magnesium deficient. And he'd had 12 cows die fitting of magnesium deficiency that year alone. Now, at the same time, that's called the staggers in the UK, that magnesium deficiency causing fits in farm animals is called the staggers. At the same time, I had a patient I was very fond of who had intractable fitting. I kept admitting him with fits. And this poor guy, I was sure he was going to die. And it's very upsetting, prolonged fitting, very, very upsetting for me, for his family. And it turned out that was magnesium deficiency caused by omeprazole. Omeprazole causes you not to absorb magnesium. And he needed a magnesium infusion, and that stopped the fits. But it caused me to think a lot about magnesium. And you're right. So most people are now magnesium deficient because if the soil is magnesium deficient, and if the vegetables are magnesium deficient, and if the cows are magnesium deficient, and then if you take drugs which mean you don't even absorb what there is, it's a really common thing. And a most fascinating subject is magnesium. And then you've got to think, I think it's helpful for insulin resistance. It's helpful for diabetes. I think it's helpful for blood pressure. It's helpful for sleep and all sorts of things. The discussion, which I'll send back to you now, Christian, is which forms of magnesium are you advising and why?
The one that I go to is magnesium citrate mostly, or also I use magnesium threonate. And the reason I use magnesium threonate is depending on the patient. For example, if I have a patient with insomnia, taking into characteristic of the consideration that it crosses the brain barrier easily, there is some suggestion that magnesium threonate can help in these patients with relaxation and with sleeping. As for magnesium citrate, it also, I think a lot of people with their diet, they're a little bit constipated, so it helps them a little bit. So it can range from 250 to 500. It doesn't mean that I give it to everybody because I'm getting into this, but the more research or the more reading that I do upon the subject, the more intrigued that I am. Because we also go with magnesium glycinate and magnesium citrate. There's some people that tolerate ones better than the others. There's other people that say that taking a bath with magnesium salts is actually a better way to get its absorption. But I usually stick to tablets. And I would say most of the time, because they can find citrate very easily. That is the one that I recommend. And threonate in the case of insomnias or other sleep disturbances.
Really, I agree completely. I tend to begin with what is the bowel habit of the person in front of me. So if they're constipated, magnesium citrate is a really good choice, and they'll thank you. If they have loose bowels, then magnesium citrate loosen them further, and they may not thank you quite as much. Isn't it interesting? I don't know whether you did, but really, for 20 or 30 years, I was giving quinine for nocturnal muscle cramps. And I'd never thought about why do people have muscle cramps? Well, they have muscle cramps mainly because they're magnesium deficient. And now I never use quinine, ever. I haven't prescribed quinine for years. I'm using magnesium and it works a lot better because quinine can have other side effects. And how odd, I never ever thought about why do people have muscle cramps at night. And when you get older, they're quite painful. You're not old enough, Christian, to have muscle cramps, I'm sure. I am. And you're hopping around the bedroom. But I haven't had them now for years. I use magnesium. The other thing I find is I do a lot of international speaking. And when I'm stressed, which going around the world speaking does, I need to double or treble my magnesium because the muscle cramps will come back if I don't, particularly if it's somewhere like Denver, or I've just been to St. Moritz in Switzerland. High altitude means I need more magnesium. Anyway, that's my magnesium story.
It's interesting because you mentioned omeprazole, and these things are given like candy. You just look and it has become like a vitamin to a certain extent. Everybody's taking that omeprazole, and then there's other things that omeprazole affects. For example, B12 deficiency. So, and then the interesting thing about B12 deficiency is that your liver has approximately 5 years of a storage of B12. But if you have not been supplementing with that, then you start having the symptoms from B12 deficiency. And that is like, it can mimic anything. It can give you neuropathy. It can get you feel tired, cranky, psychological issues. And why are people getting omeprazole? And in many cases, because they're eating crap. Why not? So
Yeah, absolutely. It gets me mad as well. I'm enabling my patients to overeat on poor food. So they know that junk food gives them acid reflux and so on. And using the omeprazole enables them to eat even more. What an irony. And of course, you are all right for a few years. This brings me to a really basic point about informed consent. And it's odd really, but so if I'm doing a surgical procedure, say taking a wart off somebody's head, you have to sign a consent form that says you understand the pros and cons of this surgery, and it could be scarring or infection. Against that, though, I can give you any drug I want to for the rest of your life, and there is no informed consent about the pros and cons of that drug. And I think that's morally and ethically a really unfortunate thing, because we should be warning patients about the balance of pros and cons of lifelong medication. And Omeprazole is a great example. So yes, it can be really useful if you've just had Christmas or whatever, or some people are in considerable pain. But using it lifelong brings side effects that you need to be warned about, because it may not happen for several years.
Definitely. One of the things that I've been focusing mostly on is, as a cardiologist, I always go for the psychology, the depression, the anxiety, because then you start seeing a pattern. You start it's like getting an eagle eye view. Because if you already have a patient that is depressed, that has anxiety, that guy or person is probably going to have some sleep disturbance. So now you've got two factors in which by themselves is affecting their cortisol, their hyperinsulinemia, their triglycerides, their lipids. And it starts generating a vicious cycle there. And that then goes with the cravings for particular foods that they should not be eating. And then they start becoming more deficient. So once you start looking into everything, you start understanding why they feel so much like crap. But then, I've even had patients, so they start having hypertension, but then they're giving medication, which sometimes that medication makes them be hypotensive. So now they feel even more like shit, but now they're depressed and they get their sertraline. So it's like you start seeing all these things and connecting the dots.
Yes.
And I always joke and I say a true physician is that who can actually de-prescribe. Prescribing a monkey can do it. That takes absolutely no science. But if your doctor has never attempted or has not been successful in removing or shown interest in removing your medication, you don't got a doctor. You got a monkey that's giving you medications. I'm sorry. It's plain fact, because we need, at least myself, they come with lonchera. I don't know what they call them, the things that the kids take to school, the lunch bag or lunch box. With 20 to 25 I joke with them and I make pyramids. It's ridiculous.
I think that's particularly important for older people, because through their lives, the doctors are adding layer after layer of long-term medication. And the truth is, we don't actually know how these medications interact. It's not actually... So the average person in the UK that's over 70 is on 7 medications. That's the average. And as you say, some are on 20. And we don't really know how these interact. The other thing I've seen often is older people have, their arteries are less flexible. So particularly in hot weather, there's a tendency to postural drop in blood pressure. In 1 week, I called 3 ambulances for people over 80 who collapsed in hot weather because they stood up because their blood pressure dropped so much. And all of them had been put on medication for their blood pressure decades earlier. And they didn't actually need it anymore because their blood pressure had actually dropped. And as you get older, your blood pressure, how do you know that you still need it if nobody ever tries to reduce the dosage or question? And they left. And it's because it's quite hard work to de-prescribe. But it's good work. It's interesting work. Find out. People can monitor their blood pressure so easily. You could try, reduce the dose and see what happens as a doctor. And I do that a lot.
Many times I think we get focused so much on the number that we forget to see the patient. And the point to that is that if I have a patient that has his blood pressure in the 120s, he is 75 and has not had history of cardiovascular events or whatever, but we're there, but he's tired all day. He's not doing anything. And I had a patient like this. He's like, Doc, I used to walk 5 miles every day. But after I was started on this medication by this physician, I just can't. I'm sleeping all day. So then you start, are you truly helping the patient? Or are you now promoting sarcopenia and all of the issues that come with sedentarism? So we have to find that in between, and it's not that clear cut in treating the patient as a number. You have to think about what you're doing.
You're so right, because what you can't look at one risk factor. Just cannot look at one risk factor in isolation. There are many risk factors, and the idea of being a doctor with some kind of skill is that you're looking at the overall risk factors, of which blood pressure is one very variable risk factor, because of course the blood pressure varies with every beat of the heart. I could put your blood pressure up. If I put a cuff on your arm, and if I say, oh, your blood pressure's high, people are frightened and the blood pressure goes higher. If you say, oh, it's not that bad, let's do it a few times again, you find it significantly lower. If you get people to breathe out slowly while you're doing the blood pressure, I did that on 100 patients, and we got the baseline blood pressure and then the blood pressure after just 5 slow exhalations. The systolic was improved by 20 millimeters of mercury on average, and the diastolic by about 12. And all they'd done was breathe out slowly 5 times. So we think when we're measuring blood pressure, we're measuring an absolute. But it's not like weight, where that is your weight or other things. Blood pressure is influenced by many factors. And of course, we don't live at the doctor's surgery. We might be frightened or anxious. And so using blood pressure as the preeminent cardiovascular risk factor has many inborn errors. And I try and go much broader than that. There are all sorts of other things I worry about, including poorly controlled diabetes. Now that really does. In fact, if you have really poorly controlled diabetes, you're losing 1/3 of your life expectancy. So that's actually rather bad and worse than moderate blood pressure or even high blood pressure. It doesn't shorten your life by 1/3, but poorly controlled diabetes does. So anyway, I'm going on too much. But blood pressure, variable, and we obsess about it. I feel too much.
I think we're getting here, the final stretch. I don't know how your schedule is.
We are.
I wanted to touch about for example, things that I do for motivation. No? I think that being able to make that click with a patient and being able to motivate is essential for them to implement the lifestyle. Now, things that I've found, I don't think I've found one person that weight loss is a sufficient motivator to continue doing this long term. But how their arteries look in the inside is less of a motivator. So then I start talking about the patients and observations, like, how do you see yourself at 80? Do you see yourself as a functional guy that can do whatever the hell you want? Because I tell them that's how I see myself. Right now I'm 45, and I see myself as working out, eating healthy, taking adequate lifestyle changes in order for me to reach 80. And if I want to go surf, I'm going to go surf. That's my goal. That's my expectation. And for example, right now, just a funny thing is I just bought my first motocross bike. I mean, I'm 45, I'm jumping, I'm doing things that I can tell you a lot of their 20-year-olds or 30-year-olds here, they're not even able to do. So for me, I love being energetic. I love being outside. So the reason for me being this is going back to the concept of happiness with your job, happiness with everything, is I hate the concept of the best years of your life being in the past. Hell no. I say that the best years of my life are yet to come, and I'm starting that stretch, and I'm going to savor them. And in order for me to savor them, I need good health. I need to build muscle. I need to be energetic. And it just pumps me up, you know? And you can, I think that a physician can communicate and transmit and infect that to the patient. And I think
if I may add something, it's all to do about the fascinating human condition. And so what you've said relates really well to very many people. I think if you're talking to people of my age, so I'm 65, the things that I really enjoy are having the energy to run with my grandchildren. So that for me is quality of life. I can sprint with my grandchildren. And, also, how long have I got with my wife? So that party will come to an end one time, won't it? But how sad if it comes to an end any earlier than it need. And so the perspective of older people is things like enjoying being active and outside, just as you say, but it's also about being given longer to enjoy your relationships and savor them. And it isn't just how long you live, it's how functional are you and how long are you going to live independently, because that's really what counts. People are losing. So many people, so many of my patients have multiple morbidity that puts them in a nursing home earlier than need be.
Yeah.
And that's such a tragedy, because although they're alive, their quality of life is actually poor. And I think we're both talking about quality of life as well as length of life.
100%. Well, David, it's been a true pleasure and honor having you here. I will do my best effort to translate this and get the subtitles to the people that don't understand it, because I think it's pure gold for them. Where can they find you? Is it mostly in X, Twitter, at Low Carb GP?
Yeah, it's at Low Carb GP. That's my thing. Twitter, and then also the Public Health Collaboration is a British charity that I help set up, and we have a website with a lot of free content for people to use, and we have a big international conference every year, usually in London, and quite a few people come from America to meet us in London, and I trot all over the world chatting to the low carb community. I've enjoyed that. You're fun, Christian. You're lively and you're fun. Well done.
Well, thank you so much. I really enjoyed speaking with you. I mean, I've been following all of your your posts and everything since I think 2017. And if in the future, I mean, we can do something with Jen, and for me, it's fabulous. Or any recommendations, because I think that food addiction and problematic foods, I mean, that is something that I really need to.
I would invite Jen onto you.
Okay.
Let's see how your audience react, and then see how it goes. But Jen would probably
They'll love it. I mean,
I think, have you done Georgia Reed? Because Georgia, good friend of mine,
yeah,
the nutritional psychiatry is really going places, and I'd highlight both Jen's work with food addiction, but Georgia Reed in nutritional psychiatry.
Definitely. Yeah. I was focusing a lot on the Hispanic thing, but I mean, there's just so much content that I have from friends and people I know. Christopher Palmer already contacted Ben Bickman. Ben Bickman is another one that I'm going to have here. And you know what? I mean, there's the subtitles. If you want to learn and you want to change your life, I'm giving you the content. You just need to digest it and read it. If you're so lazy that you cannot read the subtitles in a podcast, then you're going to be lazy. You're not going to be changing your life. So, I mean, that's the way I see it. But David, true pleasure, honestly. You have a friend here that admires you. I really want to thank you for your time. I think this was a fantastic podcast, and have an amazing day.
Thank you. I'll say goodbye to everybody. I'm going off into the sunshine now to feed my animals. I live on a farm. Goodbye now.
Alrighty. Have a good one. Bye-bye.
Bye-bye.